Hello friends, a new video, a new topic. This video is on the practical clinical physiology. It's about the examination of the pulse. So let's begin. Now first of all, I will just talk about a few things related to this topic and then we will actually perform the examination of the pulse. So let's start. First of all, definition. Pulse is a pressure wave generated in the heart and transmitted along the vascular tree to the periphery. I repeat once again, it's a pressure wave generated in the heart, generated because of the systole of the heart, generated because of the ventricular systole, and is transmitted along the vascular tree to the periphery. That's the definition. Now, why did I mention the definition? Is because very often the students mistake between blood and the pulse. They feel pulse, yeah, that means the blood flow. No, that's not the case. Look, the pressure wave, that is the pulse, it's transmitted along the vessel wall, as you can see here, and blood flows through the lumen of the blood vessel. So there's a difference. Blood through the lumen. Pulse, the pressure wave, transmitted along the vessel wall. Well, there is some bearing of blood volume on the pulse, but that's a different matter. We will discuss that later. But for now, just remember, it's the pressure wave generated along the vascular tree. Next point, whether it's an arterial pulse or a venous pulse. What are we talking about here? So let's first try to understand. Look, first thing, whenever heart goes in systole, whenever ventricles go in systole, that pressure wave will be generated and it will appear as the pulse everywhere in the body. So there will be arterial pulse, there will be venous pulse, there will even be a capillary pulsation. So first thing to be remembered, whenever the pulse comes, it means the heart was in systole at that particular moment. Systole, pressure wave created and the pulse came. The difference between a venous pulse and the arterial pulse. These are the questions which are asked in the at the first year medical school, professional exams, university exams. So let's try to understand this. Because for example, in the neck, there can be a venous pulse of the internal jugular vein, the jugular venous pulse, or it could be a carotid artery pulsation. And therefore, how do you differentiate between the two? So, here are some of the differentiating features. First, venous pulse can be seen but cannot be felt by your palpating fingers. Arterial pulse cannot be seen but it can be felt by your palpating fingers. Why? Why is this so? Veins are superficial, relatively superficial, and therefore their pulsations can be seen. So if you see the pulsation in the neck, it would be the pulsation of the internal jugular vein. But those pulsations cannot be felt by the palpating finger. Why is that? Because the veins are thin-walled, relatively thin-walled and low pressure. Venous pressure is around about 10 mm of Hg or so. And therefore, if you go on to palpate a venous pulse, the venous wall will collapse under the pressure of your fingers and you won't be able to feel the venous pulse. On the contrary, arterial pulse is arteries are deeper structures relatively. So their pulsations cannot be seen, but they can be felt by your fingers. Why is that? That's because arteries are relatively thick-walled, they have thicker walls and they have greater pressure. Arterial pressure is about 100 mm of Hg and therefore you can easily feel them. They won't collapse like a vein or a venous pulse. So if you see a pulsation in the neck, it is more likely to be a jugular venous pulse, a venous pulse. That's the difference between a venous pulse and an arterial pulse, and I told you the reason why it is so. Well, sometimes there are even capillary pulsations that can be felt. For example, if there is a hyperdynamic circulation and you press your fingers against an area of the skin, you may feel the capillaries in the finger being pulsatile. That happens sometimes, but otherwise pulsations, either arterial pulsations or venous pulsations. So, having differentiated between the two, now we come to the arterial pulse. So, from now on, whenever we say pulse, it would essentially mean arterial pulse. Okay, let me just add one more point before we start with this. When do you require venous pulsations to be checked? For example, jugular venous pulse. When do you require the jugular venous pulse to be examined? Certain conditions of heart, for example, congestive cardiac failure, heart failure conditions, when there is pooling of blood in the veins and the venous pressure rises, in these situations, you will require the venous pulse to be examined and venous pressure to be measured. Sometimes it's called a central venous pressure when you actually perform the catheterization and continuously monitor the central venous pressure. So, jugular venous pressure or right atrial pressure, or commonly clinically called as central venous pressure, is monitored in such conditions of the heart. But otherwise, now we will talk about the arterial pulse, which is today's topic. Right. Talking about the arterial pulsations, there are pulsations, arterial pulsations found at various places in the body. Starting from the toes upward, you have dorsalis pedis artery, so pulsations can be felt in the foot. Then a popliteal artery, femoral artery, then brachial artery, radial artery, carotid artery, superficial temporal artery. So, these pulsations are commonly felt in various clinical setups. For example, you will require to check the brachial artery before measurement of blood pressure by sphygmomanometer. You will require to carotid artery, very important. When do you require the carotid artery to be felt? It is for the auscultation of heart. Whenever you are performing auscultation on the heart, you simultaneously check the carotid artery pulsation. Why is that? That's because, look, carotid artery is closest to the heart. It's very close to the heart. So, the events that are occurring in the heart will get immediately reflected in the carotid artery. We have said just now that when the heart goes in systole, it creates the pressure wave and it appears as pulse, right? So, because carotid artery is very close, it's an instant reflection of those events. The systole, diastole. If you want to know the systole and diastole in the heart, we will feel the carotid pulse. Every time the pulse comes, it will be the systole in the heart. And between the two pulsations, carotid pulsations, there would be diastole in the heart. Okay. Why not other arteries? Because they are at a distance from the heart. So, there will be a certain time lapse. I mean, systole happened, vessel, the pulse transmitted. It took certain time to go and reach the periphery. By that time, the heart might go into diastole. So, therefore, carotid artery is selected for auscultation of the heart and to understand the events in the heart. This is why we select various arteries for their pulsations. There are diseases when we check all these pulsations. There are certain conditions, Raynaud's phenomena, Berger's disease. In such conditions, there may be obliteration of pulse, and therefore you tend to examine all the pulsations in the body. But otherwise, whenever we need the pulse to be examined properly for diagnosing a condition in the heart, we select the radial pulsation, the radial pulse. So, Now we are talking about the practical for today, and that's radial pulse examination at the wrist. Why radial pulse? It's simple. Radial artery can be easily felt against the bone, radial bone, and therefore the pulsation. Radial artery is relatively superficial, slightly superficial. Although I said arteries are deeper structures, but radial artery is relatively superficial and it can be easily felt against the bone, and therefore it's very easy, convenient. So we select the radial pulse at the wrist. Right. Before you start examination of the radial pulse, make sure that you are well prepared. And by preparation, I mean you should have a wristwatch with a seconds arm facility in it, or maybe a cell phone which tells with a timer, because you are going to examine the pulse for 1 full minute. In fact, the ideal is for 2 full minutes. The pulse should be examined for 2 minutes, and therefore you should have some mechanism by which it tells you the time, 1 minute, 2 minutes, right? So be prepared with that. And now let us see how the radial pulse is examined at the wrist. We are going to check it for 1 minute. So remember, keep that in mind. 3 fingers are to be applied on the radial aspect, outer aspect, the radial aspect. Many doctors, they also examine it like this. Don't do that, at least at the beginning of your career. Simple method, simple way, 3 fingers, place it over the radius bone, try to feel the radial artery pulsations. At the starting point, you may not get those pulsations easily, or they may be very feeble, very weak. So you will have to maneuver your fingers and reach an area where you feel that maximum thrust. Do that. Now you got the area of maximum thrust, maximum pulsation. So place those 3 fingers there, and now start examination of the pulse. Start examining the radial pulse. Okay, in the exams they might ask you, why 3 fingers? The doctors sometimes they also use 1 finger, but that's not acceptable. Why 3 fingers? So listen to this part carefully. Index finger, which is the proximal finger, is to compress the vessel wall so that the pulse becomes prominent. I mean, imagine a water source and a water pipe. If you just gently stand over the water pipe, what will happen? The water flow beyond that compression will become little more forceful, isn't it? Can you imagine? So somewhat similar principle is being applied here. So index finger, the proximal finger, is to compress the vessel wall so that the pulse becomes prominent. The middle finger is to actually feel the pulse. And what about the distal finger? The ring finger is the distal finger. The distal finger performs an important function. So listen to this part carefully. Look, the radial artery and the ulnar artery. These arteries, they reach the periphery and make an arch, the palmar arterial arch. So it is often that the ulnar artery pulsation reaching the wrist, reaching the palm, and then getting reflected backward and coming back like this. In the radial artery pulsation, it might get mixed. Can you imagine this? Radial artery pulse, ongoing pulse, and a reflected pulse wave coming back and getting mixed or meeting the radial ongoing pulse. Now, to prevent this mixture, there is the third finger is applied, the ring finger or the distal finger. So you can answer like this: to prevent the retrograde pulsations. Retrograde, okay, this is orthograde, onward pulsation, this is retrograde pulsation. So to prevent the retrograde pulsation coming from the palmar arterial arch and getting mixed in the radial pulsation, therefore that is prevented by placing the third finger, the distal finger or the ring finger. All right, that's how you examine, that's the method for examination. You will examine the pulse for 1 minute, ideally for 2 minutes, and you will check all these points during these 2 minutes. Rate, rhythm, volume, force and tension. Force and tension are clubbed together. I'll tell you why. Condition of the vessel wall, equality of pulsations, and radiofemoral delay. So let's start. Starting with the rate. You felt the pulsations for 1 full minute. Well, let me reiterate this again. Many students and even doctors have this tendency to check the pulse for 30 seconds, check the pulsations for 30 seconds and then multiply it by 2, so you get a pulse rate, number of pulsations per minute. That's not advisable. It should be 1 or even 2 minutes. Why? Because there are certain arrhythmias, rhythm disturbances in the heart, which do not appear, or rather they would appear infrequently. For example, second degree heart block. Every nth beat is missing and that nth beat is not certain. So therefore, in those 30 seconds, you may not get that missing beat, and therefore it is mandatory that 1 full minute at least, if not 2 minutes. Right. So let's talk about these points one by one, and then how do you present it to your examiner. Pulse rate, that's easy. Number of beats, number of pulsations which you could feel in that 1 minute, and therefore it will be same as the heart rate. Look, pulse comes with every cardiac cycle and heart going into systole. So therefore pulse rate is indicative of the heart rate, and therefore the normal pulse rate or normal heart rate in the range of 70 to 80 beats per minute, and that also should be the pulse rate that you are getting, 70 to 80 pulsations per minute. Let me make a point here. I said heart rate and pulse rate, they are same. Yes, they are. I mean, it is the cardiac cycle which is getting reflected in the pulse wave. So pulse rate is indicative of the heart rate. It should be equal. Yes, mostly it is. But in certain conditions, all the heartbeats may not get transmitted to the peripheral pulsation. All the heartbeats may not get transmitted to the radial artery pulsation. Yes, that's possible. Whenever there are arrhythmias, rhythm disturbances in the heart, all the pulsations, I mean some of the pulsations will be very, very weak. Some of the heartbeats will be very weak and they would barely reach the periphery. They may not be felt. Some of the beats will not reach the radial pulsation or may not be felt at the radial artery. And in that case, the heart rate may be what, 110, but pulse rate may be just 100. 10 beats could not be felt at the periphery. Yes, that's possible. Or there are conditions like, for example, cervical rib. There's an extra rib in the cervical region and it tends to compress the arteries which are going out to the periphery. And since it's an intermittent compression of the vessel, therefore it is compressing. So heart is beating, let's say 80 times per minute, but out of that 10 pulsations could not reach the periphery because of that cervical rib compressing on the artery, and therefore that's possible. So these are the conditions in which heart rate and pulse rate will not be same, will not be the same, will not be equal, but otherwise it is reflecting the heart rate. Remember what can be discussed clinically about the pulse rate and the heart rate. Normal heart rate 70 to 80 beats per minute, but a wider range is 60 to 100 beats per minute. Less than 60 is called as bradycardia, and more than 100 would be called as tachycardia. Now, I am not going to discuss theory part here. You may read it in the theory lectures. But tachycardia, for example, will occur whenever there is hyperdynamic circulation. Physiological conditions like exercise, anxiety, increased sympathetic discharge will cause tachycardia. And or pathologically speaking, hyperthyroidism. It's an increased BMR condition, so heart rate increases. Whereas during sleep, you will find a lower heart rate, lesser heart rate. So that's about the heart rate, pulse rate. I would appreciate if you, or I would suggest to you all to read the theory part. We will stick to the practical part. After the pulse rate, what you check for is rhythm. Now, rhythm, how do you mention? Rhythm of the pulsation should be regular in a normal subject. By regular, we mean that the pulsations are coming at regular intervals. So, if that happens, you say the rhythm is regular. Let me say this here. Very often, when the students come for clinical examination and they perform the examination and then they write it as normal, the finding was normal. No, that's an incorrect way. You should mention what is normal. For example, rhythm, normal. No. Say rhythm is regular. Pulsations are coming at regular intervals. That's the correct way. Don't ever say normal. Mention what do you mean by normal. Okay. So, pulse coming at regular intervals, and you call it as rhythm is regular. But in certain conditions of arrhythmias, the rhythm is disturbed. Arrhythmias, the rhythm disturbances in the heart, and the rhythm will be irregular. Irregular. Now, irregularity also is of two types. It could be regularly irregular or irregularly irregular. Yes. Let me give you an example. If there is a student in a class and he attends two classes and then bunks the third one, then attends the two classes, bunks the third one, then again attends the two classes, misses the third one. Now, basically, this is an irregularity on the part of the student. He is expected to attend all the classes. So, the student is irregular actually. But this is coming at regular intervals. This is regularly irregular. There is certain regularity to it. Similarly, apply the same logic to the pulse. If every third pulse is missing or every fourth pulse is missing, this is irregularity, but happening at regular interval, and therefore that's one way of describing the irregularity. This happens in second degree heart block. You know, second degree heart block has three types, and the third type of the second degree heart block, which is called as a constant block or consistent block, or sometimes it is called as 4:3 block, means atria excites 4 times, but ventricles excite only 3 out of those 4 times. That means every fourth impulse starting from the SA node could not reach the ventricles, ventricles could not contract, and therefore there was no systole, there was no pulse. Every fourth pulse is missing. So, we call it 4:3 block. Now, basically this is regularly irregular, seen commonly, as I said, second degree of heart block, third type. Irregularly irregular means completely irregular. Means two pulsations, then there are three pulses, two pulsations missing, then one pulse, then three pulses missing, something like that. Completely irregular. Well, there are conditions like ventricular fibrillation, for instance. In such conditions, the pulsations will be very weak and completely irregular, commonly called as irregularly irregular. So rate, rhythm, you are checking that in that 1 minute's time. Then volume, pulse volume. Now very often students are performing the practical for the first time and they ask, sir, how do you know the volume? How do you know the volume is normal or high volume or low volume? Okay, first of all, how do you mention the volume? Volume is either moderate, so here normal means a moderate volume, or a high volume pulse or a low volume pulse. Just like our gadgets, where we increase the volume, we call it high volume or low volume, or then the moderate volume, which is the normal in normal individuals. How do you know about these things? You will have to examine hundreds of subjects. So when you examine those hundreds of subjects or at least tens of subjects and feel how much thrust is coming with each pulse, that will tell you the story about the volume. So it should be moderate. A high volume pulse is felt in the hyperdynamic circulation. For example, as I mentioned, anemia, and the heart contracts stronger, heart rate is higher, and you feel a hyperdynamic pulse. Or hyperthyroidism, BMR has increased. You know, thyroid controls BMR, so BMR has increased and therefore heart has got the burden to supply that much blood and oxygen to the tissues. So in such conditions, you will feel high volume pulse, anemia, hyperthyroidism, etc. On the other hand, low volume pulse, very feeble, very weak pulse, barely palpable. You call it thready pulse, thread, like a thread, very thin and weak pulse. This will happen in the conditions of circulatory shock, particularly if it's a hemorrhagic shock and the blood volume has been lost. So decreased blood volume will affect the volume of the pulse as well. Or conditions like heart failure, congestive heart failure, heart is failing to pump, and since heart is failing as a pump, the pressure wave generated in the heart also would be very, very weak and feeble. So you get a low volume pulse. Then force and tension. We generally club it together, the force and the tension, because you know this, and we will discuss it in the blood pressure. There are two types of blood pressure, the systolic blood pressure and the diastolic blood pressure. So to just get an idea about systolic and diastolic blood pressure, we have these two parameters. Force gives us the idea about systolic BP, and tension in the vessel wall gives us the idea about the diastolic BP, right? So how do you check for that? Force is defined as the force applied by your fingers to obliterate the pulse completely. That gives you the idea of the force in the pulse and thereby the idea about the systolic blood pressure. The pressure needs to be applied. I am defining it again. The pressure or force needs to be applied to obliterate that pulse completely, is called as the force in the pulse. Look, if the heart is contracting stronger, the systolic BP will be higher. I mean, with each systole, heart is producing greater pressure wave. Systolic BP will increase, and therefore the pulse also will come with a certain force, and that means you will have to apply a greater force, greater pressure with your fingers to obliterate that pulse completely. We have already said this, that each time the pulse comes, it was systolic pressure or systole in the heart. So, by this method, we are trying to assess the systolic blood pressure. And tension in the wall, when there is no pulse and you feel the vessel and you try to obliterate the vessel, let's say brachial artery, you try to obliterate its lumen. When there are no, between the pulsations, when there is no pulse, try to obliterate the artery. And how much pressure is needed to obliterate the lumen of the artery, not the pulse, but lumen of the artery. That pressure indicates tension, and that indirectly tells us about the diastolic blood pressure. When the pulse is not coming, means between the two pulsations, okay? Don't misunderstand there. Between the two pulsations means no pulse. That time you are feeling the artery, you are feeling the vessel wall, you are trying to obliterate it. That gives you the idea about the tension. And obviously, between the two pulsations means what? Between the two systoles of the heart means what? During that time the heart was in diastole. So it will reflect the diastolic blood pressure. So force and tension, you can read the theory part about it. When do you get a higher force or tension, increased systolic blood pressure, the conditions causing that. That may be read in the theory part. Okay, condition of the vessel wall. You generally don't feel the condition of the vessel wall in the radial artery. You can feel it in a bigger artery like a brachial artery. Try to feel it. How do you feel the condition of the vessel wall? Try to roll the artery beneath your fingers. That gives you the idea about condition of the vessel wall. And what are we looking at here? When we look for condition of the vessel wall, we are primarily looking at the atherosclerotic wall. You know, with atherosclerosis, there would be deposition of atherosclerotic crystals, cholesterol crystals, or there would be a thrombus formation. And in such a condition, the arterial wall will be hardened. Irregular hardened artery indicates atherosclerosis. And for that, you are trying to judge the condition of the vessel wall, if it is atherosclerotic. Alright, so an irregular thickened arterial wall, if it is being felt, it's atherosclerosis, and very often it leads to hypertension. So it gives you certain idea about the patient's condition, that you had an increased force and tension and the condition is atherosclerotic. You can fairly say that it's a hypertension, and the related conditions may also be present in the heart. Right. Now only two things are remaining. One is equality of the pulsations. Well, equality as in you feel both the radial pulsations simultaneously. So you both, both of your hands are required for that. You will feel both radial pulsations for 1 full minute again, and see whether they are equal. I mean, every time the heart goes in systole, these pulsations will appear in both the radial arteries, and on both sides there would be, let's say, 80 beats per minute. So pulse rate would be 80 and 80 on both sides. So both hands felt simultaneously. I'm sorry, I won't be able to demonstrate this particular part, but you can very well imagine. Feel the arteries on both sides simultaneously for equality. Normally it will be equal. So then you would say to the examiner, the pulsations are equal on both sides, and that's the normal case. But in certain conditions, as I mentioned just now, some time back, cervical rib. Now it's left-sided cervical rib. It's going to compress the artery on the left side, and therefore intermittent compression of the artery on the left side the result will be 80 pulsations on the right side but only 72 pulsations on the left side. Yes, that's possible. So for all these things, you check the equality of the pulsations. And finally, radiofemoral delay. At first year medical school, we generally don't perform this, but anyways, I'll just tell you the background behind it. Radiofemoral delay. For this, again, you will have to feel radial artery at the wrist and the femoral artery. There should be a simultaneous examination of radial artery and the femoral artery. Can you just think it through and just tell me which pulse will come first every time? Imagine the heart goes in systole, the pulsations are coming to the peripheral arteries in all the vessels. So which pulse should come first? Have you thought about it? Femoral artery pulsation should appear before the radial artery pulsation. In each cardiac cycle, in each systole of the heart, the pressure wave generated, it will go to all the vessels and you are feeling it simultaneously in the femoral artery and the radial artery. Femoral artery pulsation is felt just before the radial artery pulsation. The difference is very, very minute. Clinically, it's almost impossible to judge that difference. So this is more or less theoretical, but nevertheless, because femoral artery is a direct branch of abdominal aorta. It's a direct branch of aorta. So, you know, heart, aorta, let's draw it here, left ventricle, aorta, coming down, abdominal aorta and femoral artery. So, therefore, there is just one branch, whereas radial artery, from the heart up to the radial artery, there are 3 branching points, and because of the branching points, the velocity of the pulse wave will be dampened a little bit. So, same systole, same pressure wave reaching the radial artery and reaching the femoral artery, it will reach femoral artery before it reaches the radial artery. Minute difference, but nevertheless theoretically the difference exists, and I told you the reason why. More the branching points in a particular tract, the velocity of the pulse will be dampened that much, and therefore it will get delayed, it will come little late. So then what is radiofemoral delay? Imagine if the radial pulse is coming first and then the femoral pulse. So it is getting reversed now. Radial pulse is coming ahead of the femoral pulse in the same cardiac cycle, okay? In every cardiac cycle, if radial pulsation comes before the femoral artery pulsation, that means what? That means somewhere here in the aorta, in the arch of aorta, in the abdominal aorta, there is some kind of a problem, and therefore the pulsation is getting damped here, slowed down here. Therefore, it reaches late in the femoral artery, and therefore femoral pulsation get delayed. So you get a radiofemoral delay. There are conditions like aortic dissection or aortic aneurysm, aneurysm of aorta, aortic dissection, dissection is a dissecting wall of the aorta, or aneurysm of aorta, a localized dilation. In such conditions, aneurysm of the abdominal aorta. So in such conditions, the pulse which is traveling through the vessel wall will get dampened if it finds a localized dilation. This is just diagrammatic. So the point being that in such a condition, you will find radiofemoral delay. But otherwise, femoral pulse should come just ahead of the radial pulse in each systole in a normal individual. Well, so that was about the examination of the pulse. I have tried not to include a lot of theory in this or a lot of clinical stuff, because this was primarily aimed at the first year medical school clinical physiology practicals. Thank you.